Thanks, Carolyn. So we have our last speaker today, who's Rajeev. And as I think Divya mentioned, the importance of a geographic aspect at this meeting, which Rajiv's providing us on top of the way geography's been used in a couple of analyses presented today. So Rajeev hails from Rochester, and he's an associate professor of ophthalmology and the director of population health at the Flaum Eye Institute in Rochester. And Rajeev uses implementation science, health services research, and informatics in his work, which he aims to strategically create, sustain, and evaluate programs for people at risk for eye disease. So thanks very much, Rajeev.
Thank you for the opportunity to talk here and come to see Kathmandu, a beautiful place that I haven't been before. All right, let's see here. So my talk is going to be on GIS mapping, looking at local data, and hopefully this is apropos for this conference. I want to give special thanks, though, to a few people, thanks to my funders especially, and thanks to a few key people. One of my questions is how do you get this thing off the ground? And you have to have workhorses like good students who really take interest in this. Anil is going on to medical school now, and MP is applying. And you also need a scientist to work with who has expertise in this area. So Alan has been a great collaborator in Western New York with me, and he is a geographer, and he has a lot of expertise in this area. So the goals, according to what I was told to do, was looking at the Congress themes and seeing how they relate to our 2030 goals, and also look at the challenges as well as the data and research that we did. So diabetes mellitus is a leading cause of blindness in the United States as well as the world, as we've seen. Cataract and glaucoma also are more common in people with diabetes, as is diabetic retinopathy, which is a leading cause of blindness in the United States in the working age population of 20 to 74-year-old individuals. Of course, an annual eye exam can prevent vision loss. I'm teaching this to the choir here that you guys all know this, but this is not really done. In the past 30 years, the health effectiveness data information set, which is a quality metric done in the United States by the National Center for Quality Assurance, looks at various key indicators of diabetes care amongst folks with diabetes in the United States population, and insurance programs, health systems look at this and see the quality of your program based upon meeting these goals. Eye care is one of them, and getting a dilated eye exam according to the HEDIS metric if you have retinopathy, which I was pleasantly surprised it's the same as the WHO goals every year. And if you don't have retinopathy, every 2 years, which is a little bit different than the American Academy of Ophthalmology and Optometry's recommendation of every year eye exams for those with diabetes. So this is a little interesting. For previous studies have reported this to be anywhere from 23 to 65% in the U.S. population. Those better insured have a higher percentage, and those with less insurance and less access to healthcare have a lower insurance, lower rate. In the United States, we like to track a lot of data, and you can see that in a lot of the studies that have been put out, a lot of population studies. So this is Robert Wood Johnson and CDC's effort looking at national surveillance and local health data. You can't read it here, but this list of things on the bottom of this chart here look at various things like dental care and cancer screenings and other things, but vision isn't there. So let's look at the area that I'm interested in, which is my home state of New York in America. And we look at our New York State data and specifically look at our own county data. So divisions of the states are in counties in the United States, and we have 62 counties in New York. And my county looks at various aspects of healthcare on a regular basis. And we look at health insurance, we look at primary care, use, dental care, cancer screening, smoking, but of course nothing on vision. The only place really in the United States that we systematically track vision across populations, not just folks who attend eye clinics, is in the driver's motor vehicles. That's it, because that's the only place you're actually getting a vision checked, either at the DMV or at your eye doctor's place to get that filled out. But no one really has looked at that across the country to really see how robust that data is to look at national vision. There has been efforts for eye health surveillance in the United States looking at vision data. So this is a CDC's initiative to put out a national survey on vision care that also includes EMR data. So the VEHSS is run by the NORC group out of University of Chicago, and it does have some good data. It does pull from EMR data. Now, EMR data is folks have actually seen an eye care specialist, so it's already biased in that realm. And the vision care data is really self-reported, and so that's the problem with this data set. It doesn't really look at risk factors for those at vision loss, and unlike a lot of your nation's registries and vision care-oriented data sets, are probably more robust than what we have in the United States on vision care. So diabetes is actually the only risk factor that is nationally tracked. The health system really cares about folks who have diabetes because they have a lot of other comorbidities and ends up in mortality, a lot of healthcare costs with diabetes. So the health system cares about it. And we have to remember that we live in our own echo chambers here at these type of meetings where a lot of us are eye focused, but a lot more of the health system isn't eye focused. Only 5% of insurance dollars in the United States goes to eye care. Most of insurance is spent on other things, cancer being a high area and cardiovascular disease being another, and of course diabetes, looking at a huge burgeoning epidemic in the United States as well. As you can see, from 2004 to 2016, the colors get brighter and brighter, meaning the population has more and more levels of diabetes. So even though we are a leading nation in the world, we have a very unhealthy population over time. So this is a serious issue. In my home state of New York, that color is also increasing over time with increasing rates of folks with diabetes. So about 12% of the U.S. Population with diabetes reported vision loss in 2018, just before the pandemic, and retinopathy is leading cause of blindness, as I said, in this population. So if you look at this across the country, this is a little older data. This is about 2013-15 data. You can see that the southeast part of the United States is where the highest concentrations of folks. Highest concentration of folks with diabetes are. And in my own state of New York, you do have some pockets of high rates of folks with diabetes going on. So why we look at diabetes is because that's a precursor for those who are at risk for diabetic retinopathy. In our state of New York, we have a 64% overall in the Medicaid Advantage Care population, which is a managed care part of the Medicaid group of insured population who are the low-income population in our state. So that's pretty good, better than national average of 50%. And but there's still pockets where this rate is lower over time, so screening is very, very important. So around the pandemic time, we thought of looking at our system a little bit more effectively, learning from a lot of folks out here who do this on a regular basis in their own countries in the worldwide setting. So we looked at our population around Rochester, New York, which is located in Western New York, and wanted to see it based upon our urban versus rural and, again, socioeconomic indicators. About 2 million people live in this area. And you can see there's substantial variation in socioeconomic status, which is indicated by the darker colors here. The blue areas are the more rural areas, and that's around the area of our city of Rochester, which is in the center. So geographic information systems uses computer systems that manage and display and analyze spatial data. We really wanted to look at eye care gaps with the socioeconomic and geographic factors for our patients with diabetes. So we looked at our own registry with 20,000 patients with diabetes in our university system. There are two health systems basically in our area, which one is a university system. And we looked at the HEDIS metrics for folks with needing eye exams. Those are DR and not DR, don't have DR. We also looked at census data and looked at the Medicaid status of our patients, and also the poverty and also geographic rurality factors that our census helps us to report, which is very helpful. And we put all of this in the geographic information system and these Coral Plex maps, which are these color scale maps of various zip codes, which is what we use. PIN codes are used in other parts of the world, and we use zip codes to categorize where people live. And we created these maps to kind of see where our population are. So our mean non-adherence rate was about 33%, and a lot of this was more common in those of low income, and those are in urban areas who are also low income, and in rural areas at low income. Those with Medicaid insurance also had a higher rate of non-adherence, which you would expect. So SES, or socioeconomic status, was a big indicator of why people weren't following up. So if you look at the urban area of Rochester, there's a lot of darker colors there. And also, if you look at some of the rural areas, there's some darker colors. But rurality alone, just by being rural, doesn't mean that you are predisposed to not have eye exam according to the HEDIS metric. A lot of people in the United States like to live in their large estates and be in private areas. So these people don't necessarily have economic issues. They like to live away from big cities where there are centers of healthcare. But there are areas in these regions that are less well-to-do, and in these areas that we have to focus on addressing healthcare needs. So we created a teleophthalmology program, like others have talked about. We call it tele-eye care, and to address the need of 7,000 of our patients who didn't have their annual or biannual eye exams. And we really focused on the city of Rochester to begin with, because that's where 50% of the population of low income exists who need eye exams, and created this camera-based screening service with 8 clinics, 5 of them being in the urban areas and 3 of them in rural areas. And over these last 5 years, we've improved services from about 43% on average to about almost 60%, with a range of 50 to 76% given your clinic. So we've identified 3,000 patients who needed this, and about 27 to 2,800 patients have gotten screened. Then we walk the follow-up, because that's also important as well, right? So for multiple years, people have been screened, 54% scheduled eye appointments at our clinic, which is the Flaum Eye Institute, and 57% of those completed. So again, you're losing about half on each of these scales that we have. And about 11% had vision-threatening retinopathy. So fortunately, there's a huge burden of vision-threatening retinopathy, but 60% of those actually followed up for eye care. We also looked at our population overall and targeted with mobile eye care telemedicine and locating new brick and mortar eye clinics over the last 5 years in areas where there were low income populations in the city of Rochester and also in the rural areas, as you can see on this map here. So our novel techniques employed looking at this cohort level data, Medicaid and census data, and combining them to address a specific at-risk issue with eye care. We did linear regression and GIS mapping to look at both the quantitative and qualitative need to provide eye care and the spatial representation. We learned that socioeconomic issues were really important more than location. So it's not like you're far away and you can't access care. It's really that you don't have means to provide for travel and other costs of providing the care. Our interpretation was really driven by socioeconomic status, as I said, rather than geographic. And our next step was to look at this data across 5 years, but issues with data have been there in the United States, and even our own health system is undergoing a lot of changes. And so we've gone to a whole different system of looking at our analysis. And so we can't get that data for the last 5 years. It's been really challenging. And this is now an issue across the United States, because our health services unit is now being transformed dramatically, and we don't know what's going to be there with our own census and our own health systems data over time. And this is something that is across the board, whether you're on the right or left side of the aisle in government, doesn't matter. Even our former Surgeon General, who was of this same leadership, said that this is really problematic for really providing effective health care, and that's been a real challenge over time. So thank you with that.